pain management is kind of a multifactorial thing, and that we don't just focus on helping a patient manage their pain, but we also help a patient improve function.
Any advanced practice procedures that you'd like people to be aware of?
We do things called trigeminal ganglion blocks, where we put a little needle in the cheek and go up through foraminal valley and place some medication around the trigeminal ganglion. And if they get relief, then we do advanced procedures where we can lesion the nerve with conventional radiofrequency, or we can use pulse radiofrequency, or even cryo, which is a freezing therapy, to try to provide long-term relief. Some of the other things, since low back pain or radicular pain, post-laminectomy syndrome, or patients who've had back surgery and continue to have pain, I think now it's called PSPS2, or persistent spinal pain syndrome type 2. There's advanced procedures like spinal cord stimulators that we may have to use, where we place little electrodes in the epidural space to block pain pathways or accentuate inhibitory pathways so that patients can get relief of their, leg pain. We can use it for arm pain. So those are a few of the more advanced things.
How do you determine if and when to adopt something into your practice?
And this is just me personally, what I do is try to look at longer term outcomes. And I mean, some of those outcomes can be looking at 5 years. And I want to see if the results in the real world mimic those that we see in, a lot of the studies that are typically industry sponsored. And our goal is not to treat a symptom. We're trying to treat the cause. So if we can treat the cause via a medicine or injection, then we can help them get off them.
This is the Get Healthy 360 podcast, where we discuss topics related to your physical, mental, financial, and spiritual health. Your host is Dr. Chris Ferguson, board certified in anesthesiology and pain management. This podcast is for informational purposes only, and you should consult your primary healthcare provider before making any decisions related to your health. And here's your host, Dr. Chris Ferguson. Oh, one more thing before we start. If you like this episode, please consider rating us 5 stars. We would really appreciate it. Thanks very much.
Welcome to Get Healthy 360. Today we have with us Dr. Miles Day, physician. He is the medical director of the Pain Center at Grace Clinic, Pain Fellowship Director at Texas Tech University. He is the Endowed Professor in Pain Research in the Department of Anesthesiology at Texas Tech University Health Sciences Center in Lubbock. He's a diplomat of the American Board of Anesthesiology with subspecialty certification in pain management. He's been doing pain management for many years. He's co-authored numerous books, chapters, and peer-reviewed articles. And he's the go-to that many physicians, including myself, will go to when we have difficult and challenging cases. So, Dr. Miles Day, thank you for joining us. Today, what we're talking about is pain management as a specialty, his thoughts on education of pain management, and then the future of pain management practice. So thanks for joining us today.
Thanks, Dr. Ferguson. Appreciate you inviting me and being here.
So first, again, huge honor to have you on the podcast. I know I've asked you questions over the years with really challenging cases, and then pretty much every physician I respect, when I say, hey, who's the go-to guy for difficult questions, they all end up texting you, and you are very gracious to respond. I do remember I had a really difficult case and you were in Italy and you responded to my text very graciously. So thank you for the education you've done for not just myself, but the field of pain management.
Of course.
Let's start with, for someone who knows nothing about pain management, what is pain management as a specialty? What do we do? What do you do?
As a specialty, I evaluate patients who typically have subacute or chronic pain to help determine the etiology of where their pain is coming from, to set up a good differential diagnosis, and to come up with a treatment plan that varies from a multidisciplinary approach where we use our psychologist, physical therapy, some medical management, and some interventional procedures to help alleviate their pain. Pain medicine has been around for quite some time. I think, John Bonica, it can be credited for being the pioneer of pain medicine in the United States back when he was an anesthesiologist after World War II. And over time, there's a lot of luminaries that came along. I was fortunately, trained by Traweek-Racz and Prithvi Raj, who are two of the foremost pain management doctors, in the world. And so I think it's a specialty that hasn't been recognized as officially yet, but in a nutshell, that's kind of what we do.
So there are different ways to explain pain management. So if you had to explain pain management to a family practice physician, so if anyone's listening, typically the way it works is you see your family practice doctor or your internal medicine doctor, and you have a pain condition that they can't control or they think needs more specialty help, they will then refer to a pain specialist. But if you were speaking to, say, a family practice resident in training or a new attending who just wasn't really familiar or didn't get adequate exposure to pain management, how would you explain who should come see a pain physician?
The patient that should come see us is the patient who has pain kind of outliving its usefulness. We sit there and explain to patients or physicians too, there's acute pain, which is pain lasting 4 to 6 weeks, and there's subacute lasting 6 weeks to 3 months. But any pain that lasts longer than 3 months is typically the pain patients that we see. So to the primary care physicians, that's what I typically tell them, is that if their therapies and following an algorithm hasn't improved the patient's life or function, then I, as a pain management physician, have more specialized training in trying to determine the etiology of where the pain is coming from, and then trying to set up, a differential diagnosis and a treatment plan. So I think hopefully that answered the question.
So the perception, and my impression is that the public perception of a pain physician is you kind of sit in an office and then patients come in and you give them some pain pills and you send them on their way. How would you have that conversation with what you do?
With what I do, well, I would tell the patient or the referring doctor that is a component of what we do as pain management physicians. That pain management is kind of a multifactorial thing, and that we don't just focus on helping a patient manage their pain, but we also help a patient improve function, and that medicines can be effective. And a lot of times patients will come in saying, well, I need an opiate. I mean, that's one of the things sometimes we get referred for. A physician will start a patient on an opiate and they say, well, refer to you pain so they can continue the medicine. And our goal is not to treat a symptom. We're trying to treat the cause. So if we can treat the cause via a medicine or injection, then we can help them get off their medication. So that's the goal as an interventional pain management physician, is to utilize procedures to get patients off of medications that sometimes patients can develop a dependency to. So it's what we do is a component of multidisciplinary pain medicine, but we're not just prescribing medications to treat a symptom. We're trying to treat the underlying etiology or cause so that hopefully patients don't need the medicine that they originally are prescribed.
Do you have any case studies or just examples of things that you do in a pain practice? For often when I speak to referring physicians or just layperson, they're not familiar with really any of the procedures that we do.
Mm-hmm. I think probably I would think, 60% of my practice is low back pain. So you've got the patient who one weekend was cleaning out the garage and they, moved a refrigerator that needed to be moved, and they experienced a sharp pain going from their back down into their big toe. So lots of pain, hard to move. They get muscle spasm. They go see their primary care doctor. Primary care doctor maybe prescribes a Medrol dose pack, some temporary medication, doesn't get better. They've got a numb toe. They send it to me. We look at them, do an evaluation, maybe order a radiological study. In this case, you might need an MRI. We'll look at the MRI. We'll see, a herniated disc pushing on an L4 nerve root. And we decide, well, then since they failed conservative therapy, that we institute maybe an epidural steroid injection. So we place steroids in the spine under fluoroscopy, an X-ray unit, and inject the steroid to help decrease inflammation around the nerve. If you can take some pressure off the nerve, the patient gets better. So that's not an uncommon, patient we see. we see patients with, chronic low back pain. They've had pain for 1 year, 5 years, 10 years. They've got arthritic changes in their facets, and we do some diagnostic blocks to help alleviate that pain. And then we do a radiofrequency procedure where we heat up the nerve to kill it essentially, to help denervate the facet joint, and their back pain gets better. Or, a sacroiliac joint injection for SI joint problems that we see this a lot in women. So these are more of the more straightforward procedures we do that I think sometimes, primary care doctors know about these, but then of course there's a lot of advanced procedures that they don't know about that, we need to spend time educating the referring doctors on what we do.
Are there any advanced procedures that you'd like to discuss that, again, this podcast is really for the general public, more family practice doctors.
Sure.
Any advanced practice procedures that you'd like people to be aware of?
My specialty, well, the thing that I like to focus on is actually facial pain. And so I have a practice where patients who have trigeminal neuralgia, which is, a lot of folks have heard of trigeminal neuralgia, where there's lancinating pain in the face. And typically it is treatable with medications like carbamazepine or oxcarbazepine. But then you have this subset of patients who don't get improvement with medications, or they have side effects. So we do things called trigeminal ganglion blocks, where we put a little needle in the cheek and go up through foraminal valley and place some medication around the trigeminal ganglion. And if they get relief, then we do advanced procedures where we can lesion the nerve with conventional radiofrequency, or we can use pulse radiofrequency, or even cryo, which is a freezing therapy, to try to provide long-term relief. Some of the other things, since low back pain or radicular pain, post-laminectomy syndrome, or patients who've had back surgery and continue to have pain, I think now it's called PSPS2, or persistent spinal pain syndrome type 2. There's advanced procedures like spinal cord stimulators that we may have to use, where we place little electrodes in the epidural space to block pain pathways or accentuate inhibitory pathways, so that patients can get relief of their, leg pain. We can use it for arm pain. So those are a few of the more advanced things. But, it seems like every year there's a new procedure that comes out for a different etiology. And so the technology is just expanding, I think, exponentially about the things that we can treat.
This question is going to be for any pain physicians listening to this podcast. So I would count myself as more mid-career, but I would say mid-career pain physicians and new pain physicians, or even family practice doctors. How do you evaluate a new procedure when it comes out? Because often there's not a lot of research. There's a lot of claims as to how great the new procedure or technique is. How do you determine if and when to adopt something into your practice?
And this is just me personally, what I do is try to look at longer term outcomes. And I mean, some of those outcomes can be looking at 5 years. And I want to see if the results in the real world mimic those that we see in, a lot of the studies that are typically industry sponsored. So I've been doing this for 27 years. We'll take neuromodulation or spinal cord stimulators as an example. When I trained, there was only one major company. There was another minor company that did them. I finished my fellowship, and I had this really cool things that I can do for patients who have had back surgery and didn't get better for whatever reason. So we do a trial where a 50% reduction in pain is considered what we need. And I'd asked a patient when we did the trial, did you get 50% pain relief? And the patient goes, yeah, I think so. And so we implanted. So I look at 27 years later, I look at kind of 5-year outcomes of my patients, implanted in 1998 to 2003, and then 2003 to 2008. And so that's a long-term outcome. I look at what I did my patients get better? So I'm a little bit more cautious. I might be overly cautius, but I don't want to do a procedure that's, is the craze today, but 3 years from now, it fizzles out, and I may have to do something new to a patient that, I went with the craze. So I'm a little bit more cautious, maybe overly cautious. I would like better outcomes for my patients when, with neuromodulation, I would hope they get 70% pain relief. And so I look at 5 years and see what the outcome is. If the data is good, if it's reproducible in other people's practice, in my practice, and I think it's a good therapy. But I try not to go with the fads because there are some that fizzle out in a year or two, and so it's a good thing I was cautious. So I wait a little bit longer, probably than most folks. I know SI joint fusions are kind of real big right now for patients with SI joint related pains. And I've been trained in 3 or 4 techniques, and I haven't done one yet because I'm still looking at a little bit more outcome to make sure that's what I think is best for my patients. So that's what I do.
So there's a lot of industry sponsored studies about spinal cord stimulators, and this is more a question for the pain physicians. And this will be a hard question, so if you want to skip it, that's fine. But do you have a favorite company? And you can skip that if you want to. But also, like, how do you determine like what brand to use? Because at least personally, I think there are differences between companies, but there are a lot of studies that argue all the companies either way. So how would you, any thoughts on that?
I've been running the Texas Tech Pain Fellowship and been involved with it running it for 16 years and being involved in it for 27. What I say is I'm an equal opportunity user. What I do in the beginning, there was one big company, and over time, a lot more have developed. The technology has gotten better, but I want my fellows to experience as many of the companies as possible so that they can get an experience with all of them. So I don't have a favorite. Now, there are times where I may, use one company versus the other because they have an FDA indication. So they've gone through a little bit more rigorous studies to get an indication for a treatment. Neuromodulation is in my opinion, neuromodulation will not work in the wrong patient, and it might work in the right patient. Because many of us have done trials that worked great, and then we did the permanent, didn't work so great. So I don't have a favorite. I try to let the fellows decide for themselves because I feel like it's not my job to tell them what to use. And I think it's gotten more complicated. When I was a fellow training, I mean, we would program our own stimulators. We had one 4-contact lead and one IPG, and you could, change the polarity, change the pulse width, change the rate, and try to do your own programming. But now it's gotten so complex. I mean, each company has their own platform which they program, so it's gotten a lot more complicated. And so I guess the answer is I don't have a favorite. I might use one if I think there's more a focal problem, maybe a DRG stimulator will work better. If it's diabetic peripheral neuropathy, maybe Nevro because they've got an FDA indication. So I will just say I'm an equal opportunity user.
So just to digress for a second, but on that topic of neuromodulation, how would you describe neuromodulation to either a family practice physician and or just a patient coming in? And when I say describe it, what is the therapy and what would make a good candidate and what would make a bad candidate?
What is neuromodulation? Basically, it's using electricity to change the way the spinal cord processes painful information. So you take little wires, you place it in a space that's outside the spinal cord, and it gets programmed to use electricity to alleviate pain. Let's see, what was the
And then who would make it? Yep, sorry, go ahead.
Okay, so indications. So most of our indications are through the Food and Drug Administration. Of course, there's failed back surgery syndrome or post-laminectomy syndrome, complex regional pain syndrome, some diabetic peripheral neuropathies, and there's some indications for angina. And I think those are the 4 major ones. But of course, we use it off-label for some other neuropathic pain conditions. Who is a good candidate? A good candidate would be somebody who has been evaluated and gone through the treatment algorithm of medications, physical therapy, possibly um, psychological counseling, minimally invasive procedures, and none of these have provided the patient with longer-term relief. And so these are the patients that you could consider neuromodulation on, and patients have to have realistic expectations as well with this type of therapy. I can't say it's the next best thing to sliced bread. It's not for everybody, but a patient has to understand that it is an implant, that we have to do a trial first, or a temporary placement of an electrode for 7 days, which I think is probably too short. Over in Europe, it's 2 to 3 weeks is what is required for trials. And if they get 50% improvement in their pain, less medication use, improved function, then they would be a candidate for a permanent system. And so, and you've got to spend a lot of time talking to patients, explaining to them exactly what we would like for them to experience from it, because it is an invasive therapy. It does have potential complications, and it's, if they do pass a trial, it's an implantable system. And then you have to explain to them, we've got batteries that are rechargeable, like your phone. We've got batteries that don't need to be recharged. It's important, I think, that the patients have a smartphone to use. I think patients who can't understand a smartphone, well, probably not a good candidate, because they wouldn't be able to, turn it on, turn it off, and recharge it. So, but that's the patient I think is, a good candidate for it. But you've got to follow an algorithm. It's not the first thing you do.
And that makes sense. So you've discussed pain management physicians do a whole host of things. They coordinate care with psychologists, physical therapists, other specialties. What are your thoughts on the education of pain physicians? Because right now, most of the people going into pain management come from anesthesia, some from physical medicine, rehab, some neurologists, etc. And then after that training, it's a 1-year fellowship, but that's a lot of information to cram into 1 year.
You're right. There are currently about 107 ACGME accredited pain medicine fellowships in the United States, and there's some unaccredited fellowships. I think back when I was training, there was a good bell-shaped curve when it came to invasive programs, non-invasive programs. But over time, a lot of the programs have kind of evened out to where most of the programs provide some of the same type of training. You're right. A year to me is not enough time, because I think a lot of focus right now, honestly, when we interview, one of the main questions from applicants is, how many procedures do I get to do? How many spinal cord stimulators? How many, mild procedures? How many interspinous spacers? And I joke that nobody asks me, how many patients do I get to evaluate in clinic over the year? Or maybe, 10 and a half months, because you got to take into vacation, state holidays and things like that. So really it's 10 and a half months. And so a lot of it is now focusing on intervention. I think it's less time is spent on how to take a good history, how to do a good physical examination, how to develop a treatment algorithm. So I really don't think that 10 and a half months or a year is enough time to really understand what we do. And so there's a lot of, thought right now is, how do you improve the education? Because the one thing that we have seen, Scott Pritzloff and Amal Wahizi and Michael Shatman and I have authored some papers looking at the state of training in the United States. The current program requirements from the ACGME really don't say, as far as interventional therapy, how many you need to have. It doesn't say how many spinal cord stimulators you need to do, how many intrathecal pumps. It's been pretty static as far as the curriculum. You have to have an experience in this, you have to have an experience in that, but it's not well defined, and it somehow has not evolved with the therapies that are being developed to make a more comprehensive pain management physician. So, right now we have a year. I don't think it's long enough. Do we need 2 years? Do we need 3 years? My personal opinion is we need to at some point have a residency that is encompassing of, learning more about interventional radiology or reading, MRIs, neurosurgery, ortho spine, rheumatology, any other, types of things can cause pain, doing surgery, because we are sometimes pain surgeons with implanting, spinal cord stimulators and pumps and interspinous spacers and things like that. So it's evolved, and I don't think our current training has kept up with the evolution of what we do.
And that makes it, I think, from a patient's perspective, kind of confusing because depending on where someone's trained, they're going to have a very different skill set when they're done. And they're just going to have a much larger or smaller treatment protocol. Let's say that, well, let's start with what are the barriers to just starting a residency for pain management? Why is that not possible?
One,
Or is it possible? It's just not being done.
one is funding. When you look at starting a new residency, since the majority of the money for postgraduate education comes from the CMS, so they fund a certain number of residents and fellows in the United States, and then there's external funding to fund the other one. So one is getting enough funding to start a residency because you have to pay residents. Two is developing a good curriculum. We need a lot of not just pain management physicians, but all the specialties to develop a curriculum that encompasses everything that we feel needs to be taught to be a better pain management physician. Three can be, board certification. Right now, board certification is through the American Board of Anesthesia, the American Board of PM&R, American Board of Psychology and Neurology. And so they are the ones that control the board certification. So that would have to be taken away from them. And so that can be an uphill battle as well. Trying to think of some other barriers.
That's an interesting thing to me that a pain physician, my understanding is it's actually a different exam. So if you're, say, like a rehab physician or a neurology physician, and then you do a fellowship, you actually take a different board than other people.
Well,
Unless I'm wrong on that one.
the pain medicine board is standard across all specialties, if I remember correctly. It's just administered by your primary training. So if you are a physical medicine rehabilitation physician, you still take the same exam that was started by the American Board of Anesthesia. It's just under AB-PM&R. If you're a psychologist or neurologist, you take it through that board. If you're family medicine, you take it through that board. So it's the same exam. It's the same subspecialty certification in pain medicine that was originally pioneered by the American Board of Anesthesia. So it's just through your primary board is how you get board certified.
Well, okay, that clears that up. So yeah, I could see why that would be confusing to like take that away, that certification away from them,
Yeah,
and hand it over to someone else.
because there's a lot of course, every year with MOCA, there is a financial interest in maintaining a board by, a specific board. But I think, initially it's got to be developing curriculum and adding and getting funding from CMS. If you can't get funding from CMS, how do you pay for residents? Does it come from the hospital? Does it come from industry? Does it come from primary donors? I mean, even my own fellows are supported in many ways, even in my fellowship. So we have our department, we have restricted educational grants from the neuromodulation companies, a little bit of money there. I have private funding. So there's a bunch of different ways. I even right now have to pay for my fellows. But if you start a residency, you've got to have all the specialties, hopefully under one roof that is involved in the curriculum. So you've got to look at big academic centers. Smaller academic centers may have a couple of the specialties that you need. So the number of residencies would start small. And then you'd have to, get interest, of course, in physicians who want to spend 3 years, 4 years just strictly on pain. So it's a bit of an uphill battle. And I guess I'm 57 and been doing this for 27 years. I'm trying to decide, in the next 10 years, do I want to seek others to help, maybe take on this challenge, what I can get done before I want to retire. So.
Do you think it's possible that pain management would ever actually become a residency, like a 3-4 year residency?
I think it's possible. Is it probable? Maybe. But there's a lot of work that has to be done. I think you probably have to survey, well, one, you'd have to look at pain medicine education during medical school, which is lacking. I think I remember, in pharmacology, okay, this is a medication, this is morphine, this is how it works, this is what it binds with. But I don't think ever remember having a class on pain management, pain medicine. So you've got to have some interest from the medical schools or in the medical school curriculum to get medical students interested in what we do. I mean, we do have rotators, fourth year and third year rotations. They rotate with us and like, oh, this is pretty neat. You do these interventions, and I think I'd like to do that, but you got to go do a residency. So we have to look at the curriculum in medical schools first to garner, survey the interest. Are there physicians who just want to do pain medicine? If there's a residency, do they want to pursue that? So that's actually something a light bulb went on as we were talking, is, looking at medical school curriculum. So talking to medical schools and trying to get that integrated into the curriculum to garner some interest.
And then so you discussed a lot of the things that you do. So you do a history physical exam, you do prescribe medications when appropriate, and then you do interventional procedures that range from steroid injections to, say, nerve ablations to neuromodulation techniques where you're actually implanting electrodes into a person's body. And then you also discussed all the new procedures that are coming out that are getting more and more surgical. And there's a gray area between pain management and, say, like neurosurgery or spine surgery. So what are your thoughts on the scope of pain management?
I think, well, what I tend to do, like the gray areas, I talk to my neurosurgeons, my ortho spine guys and gals, and actually talk to them about the newer procedures that we're coming out with, and what are their thoughts on it. Because everybody needs to play nice in the sandbox. You don't want to upset, your community's spine surgeon if you do a procedure that's bordering on what they do. So I tend to try to get their opinions on it, so that we can continue to collaborate. And that's where it comes to, is going to an industry-sponsored course enough training to do something that's bordering on neurosurgery? I don't think that's enough training. And so that kind of goes back to forming a residency. We're going to start having our fellows actually rotate with one of our ortho spine surgeons, for a couple, 3 weeks. And that's just a short period of time to kind of get an idea of the neurosurgical perspective of what they do versus what, we do. And so I don't think a weekend course is enough time to understand, putting in interspinous spacer or something that's going to change the biomechanics of the spine. And I really don't have enough training to understand that. I can get taught to put in an interspinous spacer, but do I fully understand how the biomechanics change? No. Could I be hurting the patient if I try too hard? Sure. And so we need to explore that gray area more, collaborate with our referring doctors, and try to come with an understanding that because sometimes you may need help, they may need help, and we need to help each other. So,
do you have any thoughts on pain physicians doing fusion techniques, where they're actually putting bolts in, like sacroiliac joint fusions, or I know they're the posterior, where they actually fuse those posterior spinous processes together to create a fusion, essentially, like invasive fusion.
Yeah. I think a lot of those are what I call bridging procedures. Is, one is look at the patient as a whole. If the patient has a surgical indication, but maybe not be a candidate because of comorbidities, or other reasons, something that's more minimally invasive, would be indicated. And maybe they're not a candidate for surgery yet, but they do have like some of the interspinous spacers. Put them in a little forward flexion, take some pressure off the spine, and it may help temporarily or for a few years, but then they may eventually need spine surgery. So I think they're bridging procedures that a lot of these patients may eventually need surgery, but they're more minimally invasive. Anything that's more minimally invasive has fewer potential complications. And so I think there is an indication. I think of like SI joint fusions in the right patient, they can be a benefit. And I think I was talking to somebody now, there's like 50 something SI fusion companies with lateral approaches, their posterior approaches, with different size devices to fuse the joint. Some you pack in bone, so there's a real fusion. Some are the distraction arthrodesis, just to stabilize the joint. But I still, like I said earlier, I haven't jumped on the bandwagon that says, yeah, this is the best thing for my patient. I get referred patients that, they've had one particular fusion with 3 big triangular bolts across the SI joint, and they still hurt. And it's like, what do you do for that patient? It's mechanical, it's maybe not neuropathic. What do you do? And so these things I think are needed and are effective in the right patient. And with the realization to the patient when you do it that they could require further intervention of different types in the future. So it's got to be, like I said, I always try to stick with an algorithm of treatment and not like try to hop around and come up with Miles Day's algorithm of treatment for SI joint dysfunction or disorders of sacrum. So, and we have to know our literature. We need to tell the patients what the success is and what are the potential complications. So I think we need to be honest. We're not trying to sell a car. I guess in a sense you're trying to sell a car, but we've got to be truthful. So.
Mhm. And what would your advice be to say someone who's gone through fellowship training, but then the field is advancing, but also to circle back, there's a lot to learn in just a year, like how to take a good history, come up with a differential diagnosis, make a diagnosis, come up with a treatment plan. Like that's a lot to learn in just 1 year. And then you get done and you're a pain fellow and then you get a job and you're working, you're busy and life happens and you have family and whatnot. What would your advice be to physicians that are practicing right now that want to say spot check their thought process or sharpen their skills, because you can always get better?
Sure.
Any recommendations?
I think a lot of us, well, we have to get our CMEs. So we go to meetings. A lot of times at the same topics we've heard. I think the best part of meetings is networking with your colleagues and to, like you and I have talked sometimes, hey, Chris, I've got this patient and this is what I did. What do you think? Talk to some of the key opinion leaders, the thought leaders, discuss patients. Because like I said, we go to the meetings, some of the lectures are the same lectures. And so I end up going to about 10 meetings a year, and it's the networking and bouncing ideas off of each other, I think is the most beneficial to fully, more understanding complicated things. Being able to text people, being able to call them on the phone. It's one thing to go to a course and just learning how to do a procedure, but you've got to take time outside of that to try to understand what you were taught, to understand the anatomy, the fluoroscopic images, the ultrasound images. So it's much more than just doing a procedure. It's understanding why you do it. And I think interacting with your colleagues is more beneficial and more helpful sometimes than just listening to a lecture that's quoting the current evidence. Although, nowadays when we try to get things approved by insurances, we need to know the evidence as well, just to get things approved. So that's what I would recommend is, getting to know a key opinion leader and being able to discuss things.
So that's an interesting topic about the key opinion leaders, because depending on the conference, sometimes you have a key opinion leader that's fresh out of fellowship, which I struggle to understand how someone can be a key opinion leader if they've only been in practice for like 2-3 years.
Mm.
And then there's a lot that goes into who becomes a quote unquote key opinion leader
Hmm.
um, at these conferences. So if you, let's pretend you were giving advice to a new pain physician, fresh out of fellowship, and he's going to a conference. And networking sounds great, but then how do you, what's the process of actually going about that? Like, how do you advise, say, one of your pain fellows? They're out in the world and they have you, let's say, but they don't have, like, it's a new pain fellow, but they don't have you to go and ask questions to. How do they navigate this?
Hmm. You hit some good points um, about what really defines a key opinion leader, whether or not they had done, research, so they've established themselves within a certain part of pain medicine, or they have been chosen by company A to be a key opinion leader. I don't think, I mean, sometimes people say, you know, um, Miles as a KOL, and I kind of laugh. They say, well, you're a key opinion leader. It's like, you know, I've got an opinion. You don't want to hear my opinion. But I think, you know, eh, you've got to have at least 5 years of experience, in my
Hmm.
opinion, to look back to see what you did worked and what you didn't. Sometimes you need to seek out people who are willing to talk to you, because some folks are too busy. I don't want to talk. Other people's are more approachable, and so, and I think the approachable people who are willing to talk to you, can give you useful information. Um, I I struggle like you do sometimes if it's at a sponsored dinner and the person who is lecturing is, in my opinion, essentially reading a script.
Hmm.
This is what you say. These are the buzzwords, and you're like, okay, gotcha. Um, I think people can do that, but somebody who's had many years of experience that can look back at their successes, they look back on their failures. I think you learn more from a failure than you do a success. I wish in some lectures, industry sponsored, they would talk more about a failure. What do you do if you do something and it doesn't work? Or what do you do with a failed trial? What do you do in that situation? How do you evaluate that? Do you evaluate something that didn't work? I think you garner more information out of that than you do about hearing all the successes, because everybody's got a success. All my
Hmm.
patients do great. What about those 10 patients that didn't do so well? What did you learn from that? And that's why I try to teach my fellows. So, um, seek the person who's willing to tell you the good, the bad, and the ugly. Not anybody's just telling you the good. I think you'll do better.
So to close out the podcast, and again, thank you so much for taking the time. You're always generous with your time. Are there are there any case studies that, of course, HIPAA compliant, that you'd be willing to share of either failures or successes that are memorable? Everyone has these cases that you're like, this is an interesting case, and don't do this thing, or that was a
Mhm.
really good case, and that, like, that's a great learning point.
Yeah. I in some of my facial pain patients, I have had, especially for like trigeminal neuropathies. There's more advanced cases where you can implant high nucleus, high cervical stimulators to stimulate the face. You can put trigeminal ganglion stimulators. You can put peripheral leads in the face to stimulate, the peripheral nociceptors. I can tell you three failures. They were all in patients who had postherpetic neuralgia, that they had V1 distribution, exquisite pain. Some had V2. It was PHN. And so we had done,
Postherpetic neuralgia. So for anyone who's listening, that's
yeah,
shingles of the face, right by the
yes,
eye.
you betcha. Thanks for clarifying that, Chris. And we had done medications. We had done trigeminal ganglion blocks. We had done trigeminal ganglion pulse radio frequencies. We had frozen cryoneurolysis, or freezing, using freezing to injure the nerves, and they didn't get relief. So one of the things I do, which is least invasive, is to implant off-label subcutaneous electrodes over the supraorbital and supratrochlear nerves. And these patients were suffering quite a bit. And so three patients all had PHN, and they all did not get relief. They didn't get any, they felt some paresthesias in the distribution of the nerve, but they got zero relief of their pain, all three of them. And so I've talked to other colleagues and their experience with postherpetic neuralgia and neuromodulation, and for, kind of like doing DRG stimulators and more peripheral field stimulators. They've had some success, but I can tell you in my 3 patient experience that doing peripheral field stimulation for postherpetic neuralgia and the V1 distribution doesn't work. And so I learned quite a bit from that. So if I have these patients with PHN based on my anecdotal experience, I won't be offering them peripheral field stimulation. I may have to look at other types of high cervical nucleus caudalis stimulation or even trigeminal ganglion stimulation. So I did learn from those 3 patients. So I can tell you those are my 3 failures. And even thinking about publishing it, because I think it's something that if other doctors are thinking about doing it, it may sway them from doing it. But, some of these patients are suffering so bad that you're willing to almost do anything, even with a low chance of success, to try to get them relief, because the pain from shingles or postherpetic neuralgia is one of the highest causes of suicide in the elderly. And of course, you see shingles more in the elderly population. So um, those are the things, those 3 things have definitely stood out in the last 5 years of my career.
Um, th- I have a question for you. What are your thoughts on um, stellate ganglion blocks for PTSD? Because at least in my practice, I am shocked at how well that works.
Yeah.
No one is talking about it, which is what's interesting to me.
Mhm. I think there's definitely, case studies, case series on it. Not having done them myself, other than knowing what's in the literature. I think for some of these patients, it's definitely a valid treatment. Unfortunately, most of the insurances won't cover it. I think, I don't know, are you doing that like in, VA patients with PTSD or kind of general PTSD?
VA patients with PTSD, and I've had one patient with commercial insurance who the commercial insurance covered it, and years of psychotherapy, and either it would literally cure the PTSD or it would
Mhm.
allow them then to work with the therapist to get over the issues. But it's very consistent,
Yeah.
very consistent.
Well, I think, for these refractory cases, um, I think Dr. Rax would sometimes say lack of evidence doesn't mean lack of efficacy. And so you do have to pick your patients wisely, the correct
Mhm.
ones, follow the treatment algorithm. But yeah, you have to do things like that. And if it helps a patient, great. And like the more we are able to publish our experiences, especially the successes, the
Mhm.
more over time I think we're able to get things approved in the future. I mean, it's hard to do large studies on our patients, because
Mhm.
withholding a pain treatment seems it's unethical. But the more we can get out there, even low level of evidence over time can develop into more evidence and, help the insurances understand what we can do for these truly refractory cases. So I commend you for doing that. So I don't have any experience, but I have had other physicians with experience with, PTSD.
Were they doing anything different?
No, it was mostly just, stellate ganglion blocks. I think some people do them in a series of 3 or 5, depending on the response. I can't tell you, the exact how it works because I've not really read up enough on it. But if it is able to help somebody who's truly suffering, then definitely it's something that needs to be considered.
And then any interesting success stories that you'd like to share?
Oh boy, success. Well,
I'm sure you have a ton, so
well,
I know you have a ton. So
you and I had talked about some CRPS patients,
Mhm.
and a lot of times with CRPS, the algorithm is, do a like for an arm, do a stellate, see what the success is. If you know how to do thoracic sympathetics, do a thoracic sympathetic block and radio frequency, then a stimulator. It's kind of been like those are the 3 things. Or in the, for a leg, it's a lumbar sympathetic block and then it's a stimulator. We had a patient who came to see me, and we published a case report on this, and I think it was 2004, where she had an accident where a laceration at the hand, and she developed CRPS2. Through my training with Dr. Rax and Dr. Raj, some of these patients, you would do a sympathetic block and it would help for a short period of time, but it didn't really help out with rehab. And so for this patient, Dr. Raj was he has a description of an infraclavicular brachial plexus block and infusion that he kind of helped pioneer. So this particular patient, it was regional anesthesia. I put in a catheter infraclavicular into the brachial plexus, and I infused it for 10 days with a long-term regional block. And during my resident or fellowship, we would have these patients with CRPS of a leg, and we would put in sciatic catheters or we would put in epidural catheters so that we could run a long-term infusion at the spinal cord level to kind of decrease the peripheral and central sensitization. It gave them a continuous sympathetic block, gave them a sensory block. It helped them go through PT. So there's one particular patient, we did this infraclavicular block, ran it for 7 days. She had this huge edema. And almost instantaneously when we did the block, the edema started going down. It was so bad that, she couldn't even do her own manicure. So we, gave her a manicure, cut her nails because she couldn't do it. We put her in physical therapy, did range of motion. And when she came out about 10 days later, both of her hands looked very similar. The edema wasn't there. We decreased the infusion over time. We did a thoracic sympathetic radiofrequency. And she was somebody who came in wanting her arm cut off here because it was so bad, to somebody who could reuse her dominant hand. And so that was just pretty amazing. And those are, I didn't even know about pain management when I was in medical school. I wanted to be an orthopedic surgeon. And I didn't match. I did a year of general surgery. I went into anesthesia at Tech. I didn't even know who Gabor-Rotz was, didn't know who Prithviraj was. But as a clinical anesthesia one level, first year, we had to do the anesthesia for the pain room every Tuesday. And so I spent a lot of time doing anesthesia saying, this is some really cool stuff. I mean, we get to do a little bit of surgery. We do these regional procedures. Some of these patients got a lot better. And that was kind of like, this is really cool. This is what I want to do. And then I had to go introduce myself to Rax and Raj because they didn't know who I was and I didn't know who they were. And so we started doing these infusions, but they can be labor intensive. I do them with kids. A lot of times, I was not trained in pediatric pain management, but we did treat some kids that we would do lumbar sympathetic blocks on. And a few of them, I would put in a tunneled caudal epidural up around L4, run a low dose infusion over 7 to 10 days and get them edema down, walking, and then slowly decrease infusion over time. You take the catheter out and they usually responded really well. Of course, I've done a couple of those that didn't respond. And so I think regional infusions is something that really physicians should consider when they look at CRPS. And I've had some good successes, doing that for, some refractory cases. So there's a couple of things that, definitely made me feel good, made the patient feel good, and that I was doing the right thing.
Well, it's definitely life-changing to go from wanting to chop off your arm to now your arm's working.
Yeah, exactly.
Did that patient have long-term relief or was it short-lived?
They had 4 or 5 years of relief, and this unfortunately was a workers' comp patient. Then they re-injured it. And they sent the patient lived in Dallas. They sent the patient to a workers' comp doctor in Dallas, and it took him 2 years to get back to Lubbock. And when the patient got back to Lubbock, Dr. Racz saw the patient and pretty much did the same thing that I did, and brought her back, to being able to use the hand again, less pain, no opiates, maybe a little tizanidine. So that particular patient, did well 4 or 5 years, re-injured, and from what I know, is still doing well. And this was maybe 10 years ago since Dr. Racz treated her. So, that's a good long-term success, and no neuromodulation involved.
Perfect. Safer, cheaper, great outcomes. And I think this is the type of conversation I think that in a perfect world, everyone would be able to have at one of these conferences with someone with more knowledge, experience in themselves to learn and then pass it on one day to someone else.
Yeah. I think
so.
And just to add to what you just said, I always say, you learn from your mentors, you learn from your peers, you learn from your students. So, I'm going to toot your horn. We've had some good conversations, and you said some things that, It's like, oh, I should have thought of that. So I think it's important for young doctors to understand that we learn from each other, regardless of where we are in our careers or in our training. And so you should take every opportunity to talk to others and to learn from others, and try to integrate it into your practice if you feel like it's the right thing.
I have found that the physicians that know the most and are like the most knowledgeable and ethical, they're typically the ones that are most willing to share what they know.
Yeah, I agree. I agree. I always, people are, since, I mean, I've known Dr. Racz for years, almost 3 decades. And I was just at a meeting this past weekend, and they're like, I said, Dr. Racz and I were teaching the lysis of adhesions procedure. And there was a student that said, what is this lysis of adhesions? I've never heard of it. Is it new? Why don't people teach this? And it's like, well, the gentleman that is right behind you, that's Traweek-Racz. He invented it back in the 80s. We've been doing it for, almost 40 years. It's not a new procedure. So why don't you, let me help you. I'll introduce you to Dr. Racz so that you can learn, who is the person who invented a procedure. Like I know Ricardo Plancarte, Ricardo, he pioneered the hypogastric plexus block. He pioneered the ganglion impar block. He pioneered the transdiscal splanchnics. And he's at a lot of meetings, and it's like, do you know who that guy is? You'll teach a hypogastric plexus. And I'll ask him, who invented this? And they're like, I have no idea. It's like the guy that's right behind you. You should go talk to him. And so you just take him over this. Hi, this is so-and-so. This is Dr. Plancarte. He invented this procedure. Buy him a cerveza, or to buy Dr. Racz a glass of wine and just chat. And they're willing to chat, sometimes a lot. And so, but, we just have to, continue to educate ourselves. I always joke that if you stop learning, you should retire. There's at no point in your career where you should stop learning, because it's important.
I agree. There's a ton of other things we could talk about, but I want to be, very grateful for your time sharing this with everyone. And I'll be honest, I'm going to take this podcast, and every time I have a medical resident shadowing me, I'm going to say, listen to the podcast, which is how I educate them. I give them podcasts to listen to.
Yeah. I think I need to probably listen to more podcasts and spend less time on Facebook and Instagram. So
the pain physician group you're in definitely appreciates your insights. So
yeah, it's you learn a lot from that. And that's a good forum too, because it's a good way to bounce ideas off each other, and some rub people the wrong way and some don't. But at the end of the day, we all need to do what's best for the patients, and we need to play nice in the sandbox, because at one point you may need the person who you don't necessarily agree with to help you out. So
I think those are perfect words to end on. So Dr. Miles Day, thank you again for taking the time.
You bet. My pleasure.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.